Hello everyone, my name is Chai Hong from Malaysia. First of all, I would like to thank the JSRT committee for inviting me to give a presentation in this meaningful web conference. The topic of my presentation today is the dose optimization in pediatric nuclear medicine and CT protocols. These are the contents of my presentation today. Why do we concern about children? What efforts have we done in the past 10 years? What are the dose optimization methods in pediatric nuclear medicine? What are the strategies for dose optimization in CT scan and where forward? So why do we concern about children? We have to take note that children are not small adults. Children are inherently more sensitive to environmental hazards, including radiation, because they have more proportion of proliferating cells than adults. And also, children have a longer lifespan to develop long-term health effects such as cancer. In 2012, there is a paper published in Lancet, a reputable journal, about radiation exposure from CT scans in childhood and subsequent risks of leukemia and brain tumors. It was a retrospective cohort study, and the authors reported that there was a positive association between radiation dose from CT scans and leukemia, where the excessive relative risk ERR per milligram is 0.036, the equivalent to 3.6%, and brain tumors, which is 0.023. And in 2013, a paper published in BMJ on the cancer risk in 680,000 people exposed to CT scans in childhood or adolescence. It was a data linkage study of 11 million Australians. Among 680,000 Australians exposed to a CT scan when aged 0 to 19 years, cancer incidence was increased by 24%, compared with the incidence in over 10 million unexposed people. And during 2013 as well, another paper published in JAMA Peadiatric on the use of CT scan in pediatrics and the associated radiation exposure and estimated cancer risk. So the paper reported that the projected lifetime attributable risk of solid cancer were higher for younger patients and girls than older patients and boys. And they were also higher for patients who underwent CT scan of the abdomen, pelvis, or spine. This is a graph published by the Biological Effects of Ionizing Radiation Committee in 2006. It shows the life attributable risk of cancer incidence as a function of sex and age for a single whole body dose of 10 millisieverts. The red lines indicate the trends for males and the blue line indicates the trend for female. As you can see, children has higher risk to develop cancer in their lifetime than the adults. And also girls has higher risk than the boys. In the Unscaled 2013 report that mentioned about the effects of radiation exposure of children, the committee highlighted that only 25% of the cancer types, including leukemia, thyroid, skin, breast, and brain cancer, where children are more radiosensitive than adults. Whereas the 15% of other cancers, such as colon cancer, children have same radiosensitive as adults. And 10% for cancer, including lung cancer, children are less radiosensitive than adults. 20%, including esophagus cancer, are too weak to draw a conclusion, and the remaining 30%, such as Hodgkin's disease, prostate, rectum, and uterus, they have weak correlations or none at all between radiation exposure and risk at any age of exposure. Because of the above considerations, the Unscaled Committee recommends that generalizations on the risk of effects of radiation exposure during childhood should be avoided. Attention should be directed to the specifics of the exposure, age at exposure, absorb dose to certain tissues at the particular effects of interest. They also highlight that we shouldn't just simply use effective dose to compare the radiation risk. So what efforts have we done in the past 10 years? So I summarize the activities into four main categories. The first one is Image Journey campaign, which was launched in 2007, and now they have an extension of nuclear medicine section. Second is the Go with the Guidelines campaign, was in 2008. Under this campaign, there was a harmonization guidelines between the European associations and the North American societies of nuclear medicine. And the third, there is a web-based tool named Pediatric Injector Activity Tool and Nuclear Medicine Radiation Dose Tool, developed by the Society of Nuclear Medicine and Molecular Imaging and under the Image Journey campaign. And lastly, there are a lot of posters that include the EAMM dose cut and the 2017 pediatric imaging posters to raise awareness about optimization for pediatric imaging. This is the Image Journey campaign that was launched in 2007. It's a very nice posters published by the WHO together with the Image Journey Alliance. The tagline is "Be wise, adjust for size." When you image children, kid size the procedure, adjust the protocols to control those. And 1 year later, 2008, there's another poster on the city campaign that shows a very nice posters with the tagline "One size does not fit all." So it's to raise awareness of the healthcare professionals that we should pay special consideration for children when we're doing the medical imaging. And if you log into the Image Journey website, you can see there is a special sections now. It's an additional sections, nuclear medicine resources. So there are information for different specialties, including medical professionals, information for the parents, and the radiation dose resources, as well as acknowledgement. And the second campaign, Go with the Guidelines. So this is in line with our central principle of radiation protection, which are justification and optimization. While justification just simply means do the right procedure, and optimization means do the procedure right. Okay, justification comes first, then optimization. So these are the very nice guidelines published by the American College of Radiology (SCR). They call it as SCR appropriateness criteria. Okay, they list out very comprehensively different clinical indications, what are the variants, and what are the procedures, what are the imaging procedures that's recommended, and what are the appropriateness. And they also putting down the relative radiation level. Okay, whereas in the UK, okay, they also have the similar guidelines. They call it as IREFER. Okay. However, for the IREFER, you need to subscribe to be a member in order to access their website. Whereas the American SCR appropriateness criteria are free for everyone. And recently, they have launched their mobile apps, which are available on the Android and iOS for free. So regarding the Pediatric Dosage Harmonization Working Group, actually since 1990, the Europe has recommended dosing for radiopharmaceuticals. And in 2007, the European Association of Nuclear Medicine, they revised their dosing information and they published the EANM dosage cut. Whereas 2010, the North American, they have their own guidelines, okay, for pediatric radiopharmaceutical administered dose. And in 2014, okay, it's a big effort that these two big organizations, one European Association of Nuclear Medicine as well as the North American Society, they sit down together and they came out with a harmonization guidelines. So developed on the harmonization working group was the ENMM dosage cut versions 2014. And 2 years later, the North American also published their consensus guidelines for pediatric administered radiopharmaceutical activities. So this is a big effort that both organizations have has taken into effort, and they come up with a harmonization guidelines between Europe and the America, and the guidelines can be used for all other countries in the world. These are the examples of the ENNM dose card 2016, and this is the PET dose app developed by the Society of Nuclear Medicine and Molecular Imaging in America, and you can download it in your Android or your Apple phone, and it will show you what are the recommended administered activities for different weights of the patients. These are the websites of the Society of Nuclear Medicine and Molecular Imaging. If you go to the Peadiatric Injected Activity Tools, okay, you can select the imaging procedures and key in the patient weight, and there will be recommendation for you, one by the North American Society, one by the European Associations. So what are the strategies for dose optimization in pediatric nuclear medicine? First of all, it's very important for us to realize that not necessarily the highest image quality or the lowest radiation dose is always good. The imaging should provide adequate information for the indicated diagnosis, not excessive, not less. We can consider this as doing the right test for the right indications at the right time. So I have listed 6 methods here. First of all, refer the guidelines as we have discussed just now. There are 2 main guidelines, one from the Europe, another one from the North America. And if you have a national DRL, then you can follow the national DRL guidelines. And second, justification means do the right test for the right indications at the right time. Third, optimization of current protocols. Fourth, improvement of the software, improvement of the hardware, and finally, public education or patient education is as well important. Okay, now let's jump to optimization of current protocols. I take example from Travis study in 2017 showing a technetium 99M Mac3 using ultra-high resolution collimator. It's a no-flow study for 10 kg 9-month-old boy with hydronephrosis. According to the guideline, the recommended administered activity is 1 millicurie for 10 kg patients. However, Travis et al. They used 0.22 millicurie. By doing so, they reduced 78% of radiation dose to the patient while preserve the clinical information from the imaging. Another example, technetium 99M disulfiram, no-flow study for a 2-day-old boy with choledochosis. The recommended dose is 0.5 millicurie. However, the Travis group have tried 0.15 millicurie and image quality preserved and achieve a 70% of dose reductions. Okay, software. There are some advanced image processing software. For example, in SPECT and PET scan, the newer software is called OSAM 3D. OSAM is an iterative reconstruction method, and for planar imaging, static or dynamic, there is a noise reduction method called enhanced planar processing. Let's look at this OSAM 3D with resolution recovery. OSAM 3D definitely does better than the filter back projections. It provides superior image quality and requires much lower count. That means we can reduce the patient dose, or if we want to preserve the patient dose, we can reduce the scan time. When we reduce the scan time, it can possible to reduce patient motion, so we can achieve a better image quality and the need for sedation. So we can choose either we can lower the patient dose or we improve the image quality. So let's look at this example, technetium DMSA SPECT imaging. This one, the first image is for full count using filter back projection. Second image shows only using half of the count and using the OSAM 3D reconstruction. And the last image shows full counts OSAM 3D. So image quality, the cortical defects identify better with OSAM 3D. OSAM 3D identified defects not seen on the filter bed projection. No significant difference in differential reader function or size, and in terms of image quality score, OSAM actually does slightly better than the filter bed projection, and the most important point is they use 50% less count, means 50% less dose. Another example is the Technician 99M MDP SPECT scan for a 17-month-old boy with a right suprarenal mass. The first image shows a full count acquisition and using filter bed projection reconstruction. And the second image shows only half of the count and using OSAM 3D reconstruction. In terms of image quality, OSAM 3D with 50% count is better than filter bed projection full count. So OSAM 3D able to reduce noise and improve the ability to detect lesions. Then not only that, it also reduce the patient dose by half or reduce the scanning time by half or a combination of both. This example shows the enhanced planar processing EPP used in planar imaging. The first image shows the original image acquired using 100% count for a 2-minute matrix study. Then the count was reduced to 50%, 30%, and 10%. The top panel's images shows the images without using noise reduction software, whereas the bottom images shows the subsamples with noise reduction software. And you can see even though the count was reduced to only 10%, but by applying the EPP noise reduction software, it's possible to filter out the noise and preserve the clinical information. So this group of researchers, they did a study on the image quality by qualitative assessment by the clinicians. So they rate 0 to 100% excellent level. So this result is before doing the EPP noise reductions. So as you see, the counts lower, the satisfaction level is lower. Whereas this is the results after they done the noise reductions using the EPP method. So for baseline means 100% count, and you compare the 50% count with the baseline. Okay, not only the dose was reduced, okay, the image quality or the satisfaction level by the clinician are also higher. It's almost achieving 100%. Next, hardware. There are a lot of improvement has been done on the hardware. For example, we have newer detectors, which is like fully digital detectors, such as the cadmium zinc or the CZT detectors. Most of these systems can improve image energy resolution, improve geometry and spatial resolution, faster acquisition, improve processing, and some of the machine using advanced robotics. So next, what are the dose optimization strategy in CT scan? CT scan is a relatively matured technology. There have been a lot of improvements and developments done in the past decades. And for those optimizations, mainly the protocols are specified to age, body size, and composition. Taking the first example of automatic tube voltage, KVP adjustment, and we know that adjusting the KVP will adjust the penetration power of the X-rays. In a general rule, for thicker patients, we use higher KVP. However, if you lower the KVP and the MAS remain unchanged, it could reduce radiation dose and improve image contrast for small-sized patients. This can be applied for high-contrast subjects tissues such as the chest and bones. However, in contrast-enhanced soft tissue procedure, such as to assess small lesions in the abdomen, the use of higher KVP is necessary. It is difficult to justify in practice. Therefore, the modern system that have this called automatic KVP selections with MA modulation functions. Then we have tube current modulations, MA. We know radiation dose is proportional to MAS. By using the MA modulation function, the system will automatically adjust the MA based on the size and attenuation properties of the body. By doing so, the dose can be reduced by 26 to 50%. However, this function is very much manufacturers dependent. It means different manufacturer use different algorithms. For example, Siemens call it as K-dose in their system, or K-dose for D. In Philips, they call it D-DOM and Z-DOM. In GE, they call it Smart MA, Auto MA, and Auto MA 3D. Whereas Toshiba calls Sure Exposure and Sure Exposure 3D. Similarly, for the iterative reconstruction, it's also very much manufacturer dependent. And in GE, they call it as VEO. Siemens call it as Sapphire. Philips call iDose 4. And in Toshiba, they call it as adaptive iterative dose reductions. And finally, we can optimize the scanogram or scout view. By placing the X-ray tube under the table for scout view, can reduce dose to 1/3. And the scout view should only cover the region of interest. And lastly, we can also optimize the pitch and scan collimations. Optimal collimation is very important in dose reductions and avoid unnecessary radiation to other parts of the body. And next, I would like to talk about the use of CT in SPECT-CT and PET-CT. When is it necessary to use CT? The CT protocol is depending on the application. If the CT scan is truly only for attenuation correction, both kVp and MAS can be reduced to almost as far as the device will allow. For example, 80 kVp and around 10 mAs. In many cases, low-dose CT is used for anatomical correlation of the PET data. In these cases, the CT image quality may only need to be sufficient for localization and less than that necessary for diagnosis. If the CT is used for diagnostic purposes, then the diagnostic CT protocol should be used. But one should keep in mind that diagnostic CT should only apply to the region of interest while delivering low-dose CT to the rest of the body, especially during whole-body PET-CT scan. So what are the way forwards? We should continue to refine and disseminate our guidelines. These are the responsibility of our regulators. Improve communication with patients and caregivers. Optimize existing protocols to be task-specific and personalized approach. This has to be a teamwork between the radiographers, nurses, medical physicists, and researchers. More advanced image processing software or methods. This one we have to rely on our R&D team. And lastly, more advanced and affordable equipment. This we have to involve our manufacturers. And always remember, our goal is to do the right test for the right indications at the right time. Thank you very much for your attention.